The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety.
So you're going to have to, I'm going to butcher your name. I just,
you know
will.
what?
I will.
No, but you can call me Jeff if you want.
What?
Jeff.
Yeah. Are you serious?
Yeah, because like Jean is like John and Francois is like Francis. So it's like John Francis, basically. That's my name. But everybody, like in French, people call me Jeff for real. Like my dad calls me Jeff. So you can just call me Jeff.
Serious?
Like Jeff.
So yeah. Evan, do you hear that? I can call him Jeff.
Or some people do the, JF, like the initials.
Okay.
So it could be JF or Jeff.
That's good.
Yeah, that's actually how people call me in French, which is kind of weird.
Well, Evan, you can't call him Jeff. So you just understand that. This is a privilege that I get for traveling all the way here to spend this time with him.
Yeah, when you come to Montreal, then you can switch to the English version.
Yeah.
This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Today's podcast, we are here in Montreal, Canada, here with Jeff. Want him to introduce himself. Real excited about this podcast. Just traveled up here for a course in upstate New York, and I'm on my return leg, and we've had this set up for a couple of months now. Excited to be able to see you and spend this time with you.
Yeah, thank you so much for having me. Really excited to be here in person with you. So my name is Jean-Francois, or Jeff, which is obviously easier. I'm an emergency physician. I've been working in emergency medicine and critical care for the past 11 years on the South Shore of Montreal, Canada. And I am also co-founder and director of operations and the adult section of our app, which is called Easy Resus, the resuscitation assistant.
Nice. Well, and you probably heard or saw the different advertisements that have come out through our MailChimp or, through the website where we have aligned with Easy Resus and the app, and we're going to cross-pollinate each other's brands and work together to, grow. And so real excited for that opportunity and excited to be able to be here today to talk about medicine, right? And talk about maybe how we can use apps. I think historically, if you looked at me, I'm probably more old-fashioned. I don't tend to use apps to their full extent. I'm probably a late adopter when it comes to stuff like that. So trying to change that, right? Definitely use apps for pediatric stuff, for medication dosages, for drip rates, for drip calculators. I think there's a lot of value. And obviously from the pediatric side, our associate medical director and close friend, Peter Antevy, and his pediatric Hantevy system is obviously an invaluable resource for pediatric resuscitation, right? And I'm really excited to be able to talk about and highlight your app and just get users out there to try it and see what it can do.
Yeah, absolutely. Thank you so much. And so we're really excited to partner with you guys as well. I think we have a lot of things in common and a lot of things to share. And if anyone has anything to, comments, questions, suggestions, please write to us. We're more than happy to make this tool the best it could be.
Well, so I presented this case to you about a month ago. We wanted to come up with a good case. Obviously, over the life of the podcast, we've done the Nightmare Series case study. And we have had a lot of great cases. And I think that's really one of my favorite ways to present medicine, right? I think we can reflect on cases that we've had, reflect on maybe what we did right, maybe what we did wrong. Love having a physician like yourself on here to bounce things off of. And, I love that you're a Canadian physician as well, because I want to talk about maybe differences that you see from a perspective standpoint. Maybe there's no differences, right? Maybe the medicine is very closely aligned. And based on our pre-podcast conversation, it sounds like it's very, very close. So I did present this case to you about a month ago. This is a really sick DKA case that I think has got a lot of value. There's a lot of great teaching points. And I think DKA is definitely a disease process that can challenge even the most seasoned provider, right? And so really what we're going to do is present this case. Really, he's going to do a lot of the back and forth with some of the areas that we can see maybe from a treatment standpoint and talk about why we do what we do. Sound good?
Absolutely. Let's go.
So if we dive into this case, this is a 24-year-old male patient that was brought in by EMS to a small hospital. He had been here about 3 to 4 hours. He was unresponsive when he arrived. He was intubated by the ED staff successfully, currently being sedated, ongoing with propofol, and he's been given multiple medications. He's got bilateral IVs, 18 gauges. He's had recently 1 amp of bicarb. He's been given an IV bolus of 10 units of insulin, and he's on an insulin drip. And we're going to talk about the insulin drip. He's also hemodynamically unstable, and he's on a norepi drip at 0.14 mics per kilo per minute if you're using mics per kilo per minute. And so at this point, let's just talk about the initial thought process. If this patient came into your ED, what is your initial thoughts on assessment, treatment, and stabilization?
Yeah, for sure. And first of all, I mean, really, really sick patient. So, good on the team for taking care of that patient and for, securing all these things and for the initial resuscitation. So, that's number one. After that, obviously very sick patient, pH 6.8, bicarb is like in the single digits, potassium 7.4. So, a lot of things going on. At first, what really I found was a bit not necessarily odd, but a bit atypical was how unresponsive the patient was described to be when he came in. So like already GCS of 3 when he came in, which, very sick DKA patients are often obtunded, but to be like completely unresponsive, I just find that's a bit atypical. So that would just, ring a bell in my head just to say, is there something else going on? Should we think about, a head trauma? Should we think about, obviously these patients have a lot of mental health issues. Should we think about intoxications? And just so, broaden a little bit your differential at the beginning of the case and as things progress. So that's number one. The other thing is, and we were talking a little bit offline, the numbers, when you look at the sheer numbers of these patients, it's really impressive, pH of 6.8, potassium of 7.4, bicarb in the single digits. Just looking at that, if you don't know it's DKA, you'd be really impressed. And it's impressive how these patients tolerate these physiological and metabolic changes so well. And it's impressive how they'll turn around very fast once you get the treatment started. So I think that those are, the first thoughts that I had when I saw the case.
Yeah, so let's go through the labs. Initial sugar was 827, sodium of 121. So I do want to talk about corrected sodium in DKA. Chloride of 90. He's got a serum bicarb of 5. K, as you said, was 7.4. ABG, he's got a pH of 6.8. He's got a CO2 of 8. PO2 of 191, which matches. And he's got a base excess of negative 29, base deficit of 29, with a bicarb of 1.2, right? So almost non-existent there. So what are you thinking based on those labs?
Yeah, so those labs that we were saying, for me, they align pretty well with a very sick DKA patient. Once again, because of the neurological status, I probably would have looked a little bit about, trauma, toxins, and that kind of stuff. But otherwise, I think, if this is really a DKA patient and you've ruled out the other things, and certainly I think in this case, as we saw a little bit more, like obviously one of the main things are medication non-compliance, which is, the main issue probably in these patients. But you do want to think about the other things like what brought this on, like infection or a heart attack or pancreatitis or all these other things that could be going on. But otherwise, I think, these are pretty numbers that we'll see on a pretty standard fashion for sick DKA patients. So for me, I would just, go ahead and start with my protocol for one of these patients.
So how often do you see a patient in DKA with a bicarb that is that low? I know that there's been questions in courses about bicarbs that critically low. Is that normal to see that? I know. And how aggressive are you with giving a replacement bicarb?
Yeah, so I've seen this quite often, actually, the bicarbs that are that low. And most often, obviously, once you've ruled out the other things and made sure there's nothing else going on, I think they could be, they could certainly be just because of the DKA. Okay. In terms of giving sodium bicarbonate, I think, you could probably do a podcast about giving sodium bicarbonate about all these different indications just because there's, so much back and forth in the past 10 or 20 years. The situation right now is really the ketotic state caused by the lack of insulin. It's not a lack of bicarbonate. So, this is just like a byproduct of what's going on. So, when you look at the studies, obviously they're very small and are not randomized, but there doesn't seem to be very, any benefit at all to giving sodium bicarbonate to these patients. Some guidelines will still recommend giving it when the pH is below 6.9. I think it's probably more to, treat the practitioner than to treat the patient, because what's going to, get your pH better is giving insulin to reverse that ketotic state. That's really what you need to do, obviously, to get this patient better. You do have to keep in mind that sometimes there will be mixed problems going on. So if you do have, if you started resuscitating the patient and the patient already has like a bit of a non-anion gap metabolic acidosis going on, then maybe bicarbonate could be like something that you could administer. So if you find another reason to give bicarb, certainly I think that could be a solution. But if it's really like pure DKA and you're saying, is bicarbonate going to help my patient? The answer is probably no, although we don't have that answer for sure. And the answer is going to be to, get your stuff started and get insulin going.
Yeah, and that's always a hot topic in any of the courses we do. Definitely a hot topic. We did do a podcast with Will Heuser. He's a PharmD out of New York, a close friend of FlightBridgeED's, and really that topic was on basically at what level does pH start affecting medications, where you're giving the bicarb to improve pH, so medications act on receptors better, right? And, DKA is a completely different animal. And I think we talked pre-show, right? A patient that is 6.8, 6.9, that's DKA is a much more stable patient than a sepsis patient, multi-organ failure patient with a pH of 6.8, right? Which is probably that's on death's door.
Yeah, absolutely. They tolerate low pHs. It's really impressive. 6.8, 6.7. Sometimes you'll see even lower than that. And the next day they'll be like, texting on their phone, which obviously if you have a pH like that, when you're like post arrest or sepsis or whatnot, you won't be doing so well 24 hours later. So, those numbers are really impressive.
All right. So some other things with this case. So we talked about the pH. We talked about the ABG. Let's talk about why is the K high?
DKA is, we talked about acidosis. So that's the number one thing you really want to, take care of that. And the way to take care of that is insulin. People think that you need to, give insulin to get the sugar lower, but we don't really, we care about the sugar, but that it's not the high sugar that's causing the problem. It's the ketotic state, right? So insulin is your treatment for that. The other big problem, and this is where you can really screw things up, is the potassium. And the reason why you can screw this up is because these patients, unless there's something weird going on or they're on dialysis or something like that, they will be whole body potassium down like most of the time. And they can have deficits in potassium like in the hundreds of milliequivalents. It's really, really impressive.
Wow.
And the reason for that is, there are a few reasons, but the main ones are, especially the new undiagnosed patients, they have been, having polyuria for weeks, sometimes months. And the reason for that is obviously your sugar's high. And so your sugar, you're urinating sugar. And so that's pulling up water into your urine. So you have glycosuria. So it's pulling water. You're getting dehydrated, but it's pulling potassium as well.
Sure.
And because of all the shifts, the osmolality shifts and the acidosis as well. So that's pulling potassium as well. So they will be whole body potassium down like hundreds of milliequivalents. And so most of these patients will actually be hypokalemic. In this case, probably what happened is as the patient was getting acute kidney injury from his dehydration, then what happens is the potassium, the intravascular potassium, you're actually seeing getting a bit higher just because he's probably stopped urinating at this point for a few hours. And because of the acidosis, right, the pH is 6.8, so you're seeing transcellular shifts as well. So your potassium is 7.5 is what you're measuring intravascularly. But the real story in these patients is they are potassium down. Like some patients will not be, as we were saying, like the dialysis patient is a good example, but otherwise you really have to be ready to give potassium. So in this case, I see 7.4 potassium. I am super happy. And the reason why I'm happy is the two next things that I'm going to do are, give this patient IV hydration, which is probably started anyways. But just by hydrating the patient, you're going to dilute, air quotes, the potassium. You're going to rehydrate the patient. You're going to, help the acute kidney injury, get them urinating again. So that's going to be good. The other thing is just by IV hydration, you're going to get the pH a bit higher as well. So that's going to start shifting your potassium. And the other thing is when I'm going to start my insulin, that's going to shift my potassium a lot. So I am happy when the potassium is high. And so, you're going to see in this patient, you check the potassium 2 or 3 hours later, and the potassium is going to be probably even in the normal range and maybe even in the low normal range. And then you're going to have to start repleting. That being said, we should have started by saying, obviously, when the potassium is 7.4, first thing you want to do is do an EKG. Just make sure there's no EKG changes. Put the patient on a monitor, make sure there's nothing going on. But, personally, if, the EKG looks fine, monitor looks fine, I wouldn't even go with giving calcium at this point. It's just, the potassium is going to drop so fast that you're going to take care of that pretty rapidly.
Love that. Like that was so huge. So at what level, if this patient came in, would you immediately start giving potassium?
So if typically what we use in terms of guidelines, yeah. So if we aim for a potassium of 5.2 or 5.3, something around there. And you really want to, work very hard to keep it there. If your potassium is between like the 3.2 to 5.2 range, then you'll give potassium. And if you're below 3.2, you can't, you shouldn't start insulin actually, because that's how you run into problems. Because if your potassium is 2.8, for example, and you give insulin and these patients are potassium down, what's going to happen. Their next potassium check is going to be 1.8, or you won't get to their next potassium check because they'll be in torsade and then, they'll go into ventricular arrhythmias. And so you really, want to get on the potassium bandwagon as fast as possible. And, I'll tell you my record, I've given over 2-3 days, over 800 to 900 milliequivalents of potassium to these patients in a mix of PO and IV. And, I remember this patient, he was like at 3.4 and we were giving like 40, 60, 80 milliequivalents an hour. And the potassium would not budge. Like it would go up to like 3.5, 3.6.
Like, where's it going?
Yeah, where is it going? But that patient has been, urinating for weeks and everything. So, that's really a major point for these patients. Look at the potassium, check the potassium, give potassium. And, at the beginning, if the potassium is high, don't worry. It's not going to stay high for long. You're going to get there. It's the other problem is going to come up fast enough.
Well, and that's interesting because, when we teach our courses and we do these case studies, it always is a hot topic. And, and it's just maybe not understanding. And, you have taught me a lot in just this conversation, right? But it is a knee-jerk reaction. I see it all the time. I see it every class where we want to treat it. We want to drop the potassium, right? You walk in, you see a 7.4, like, oh my gosh. And I try to caution them to say, take a look at the patient, evaluate, is there any EKG changes? It's not peak T waves. Is there any blocks? Is there new onset, heart block, slow, wide VTAC, things like that? Do you see anything, before you just automatically, do that? And I think, we're a lot of us are of the mindset, we want to see correction. We want to drop the sugar. We want to fix the ABG. And I think it's important what you said. It's a slow process. Let the ICU do a lot of that work, right? It's about that initial resuscitation, stabilization of that patient.
Yeah. And if I can, do a final note on potassium, I've seen cases as well where the potassium is below 3.2, and that should actually stop you from starting insulin, as we were saying. And then the problem is you're fighting, to try to get your potassium up, but you really have to wait for your potassium to be in the normal range before you get insulin started. That's one of the things that, people get wrong sometimes is, they'll see a DKA patient, they see a sugar of like 800. So they'll give a bolus of whatever, ideally, a balanced crystalloid, and then they'll start insulin right away. But, you do want to start insulin, but you really want to wait for your potassium level before starting insulin. Just by giving your 1, 2, 3, 4 liters of bolus, you'll get your sugar down, you'll get your potassium down, you'll help your creatinine. Everything's going to get better just with IV hydration. That's what they need at first. They're going to be fine. So just, sit on your hands for an hour, or however long it takes for your potassium to turn around at your lab. And once you get your potassium value, then you can start going and treating an insulin and everything. But at first, it's really just IV hydration and making sure, you're covering your bases in terms of differential diagnosis, and then just waiting a little bit.
So that segues to insulin drip, right? And it's interesting. I love your thought process. Did a podcast with Ashley long time ago. It was called the Endocrine Nightmare. It was on a DKA patient, younger patient like this, where the hospital, they were very aggressive with dropping the sugar. Dropped the sugar 500 points in the first hour and a half. Put her into cerebral edema, and she ended up passing away. And so one of the conversations that we had, and she corrected me on the podcast, everybody loved that, was, in that circumstance, do you shut the insulin off? Her mindset was exactly what you said about, it's more about the acidemia. And she, they had a huge insulin drip. I mean, huge. That it's about turning the insulin drip down to a really low number, but not shutting it off, because you still want to be treating that acidemia. And so, I think that comes down to, this topic here. This patient was actually on an insulin drip of 0.3 units per kilo per hour. So talk about that dosing. That definitely is 3 times the standard dose. And what is the positive, negatives, if there is any positives? How much should we be dropping our sugar every hour?
Yeah. So basically you want to go between like 50, 70 or 100, milligrams per deciliter dropping your sugar. I think that makes a lot of sense. Sometimes it drops a little bit faster at first. When you hydrate them, you'll get a bit of a drop in the first hour or two, but then for sure you want to check and not make it drop too fast. And obviously that's what you were saying, with that sad case, because of all the shifts that can happen, and you don't want osmolality to shift too fast. And so that's important. You will have 2 regimens that you see out there. Some will bolus 0.1 units per kilo of insulin first, like IV bolus, and then start the drip at 0.1 units per kilo per hour. Some protocols will do the 0.14, so 1.4 units per kilo per hour, without a bolus. And you can mix and match a little bit these things. And so that's basically what you'll see. And the reason why we don't go higher is, for one, like you were saying, you don't want to drop your sugar too fast. Number 2, we were talking about potassium. So obviously, you want to be careful about that as well. And, it's DKA is not a sugar problem. I mean, it is, but that's not what you're trying to correct. That's not your main goal. You're not trying to get the sugar down as fast as possible. Contrary to that, you want to drop your sugar, but you want to do it, in a corrected fashion. And so, by going through all that, the studies in the past, that they found that, that's probably where the sweet spot is. The only difference I would be saying, if you have a patient with a very, very low pH, instability, you're very worried about, you could temporarily, increase your insulin drip rate a little bit, because obviously that's what's going to make your pH better and not bicarbonate. And so you could probably go up to like 0.2 units per kilo per hour just for an hour or something, just, temporarily to make your pH a little bit better, a little bit faster. But after that, I would definitely drop down to like their 0.1 or 0.14 units per kilo per hour and just letting them go. And most of the time things will correct at a good enough pace, not too fast, not too slow with these doses. And so there's really no indication that I could think of where you would want to go up like 0.3, 0.4, 0.5 units per kilo per hour insulin. You're only going to, drop your sugar too fast and cause problems with potassium and everything. So I would certainly be more conservative with that.
All right. So let's come back to the labs. Obviously, I said sodium at 121, chloride at 90. What are your thoughts on the corrected sodium? Is that something you do, routinely? Obviously we corrected the sodium here and it corrects to a 135. So talk about the importance of that and why we should do that, and how does that guide your clinical decision making?
Yeah, that's really interesting. Corrected sodium for sugar is actually, the hyponatremia that you're seeing in this patient is actually true hyponatremia. So it's not pseudo in the sense that the lab measure that your lab is measuring is a true number. The problem is you're going to correct the glucose. And so you're going to cause so many shifts in osmolality and shifts in water that when your sugar is going to be corrected in a few hours, what you want to know is, where is your sodium going? Because what happens is, some of these patients will show up with a sodium of 138 or 139, but the glucose will be 1,000. And now if you correct that, now I don't know the formula off the top of my head, but sometimes you'll be at a sodium of 155.
Okay.
And so you want to know that, because if you have a balanced solution and you want to, IV bolus and IV maintenance with a balanced solution, you'll probably be okay most of the time. But if you don't, and you want to choose like normal saline or a half normal saline, the problem is if the corrected sodium, so that means that once you're going to correct the glucose, your sodium will be 155. Then ideally, you don't want to give normal saline, because you know that you have a water deficit in that patient that's a bit greater than what you probably thought initially. So the best is probably to rehydrate the patient with a hyperosmolar solution, which is why you would want to use half normal saline in these situations. So that's one of the reasons why we want to correct sodium at first. If you're using a balanced solution, it's a little bit less important, because, something like lactated ringers, you'll have your sodium is probably around like 130 milliequivalents. And so even if you're a bit hypernatremic, it's going to correct it down just by giving fluids. If you're a bit hyponatremic, it's going to bring it back closer to normal. So it's a bit less important. But for places that just have, normal saline or half normal saline, it's really important to correct your sodium. In our protocols, we use 140 as the cutoff. So if your corrected sodium is below 140, then you could use normal saline. And if your corrected sodium is above 140, then you would want to use half normal saline, just to make sure that it's not going to get your sodium even higher.
All right. So let's talk about now the mechanical ventilation piece, right? And I think we had a good discussion prior. I think in most cases, we teach obviously, the minute ventilation calculation and looking at maintaining that compensation, allowing them to continue to blow off that CO2 through respiratory buffering. This patient is obtunded, unresponsive, intubated, but would you agree that that's probably not the standard, right? If you can maintain these patients on their own ability, whether that's non-rebreather, nasal cannula, or even non-invasive, or many of us have now high flow nasal cannula technology, right? But it's usually not a lung issue. It's not a respiratory issue, correct?
Yeah, absolutely. No, I completely agree. And these patients, when he came in, he had a CO2, was it 5 or 8?
Yeah.
So, these patients can blow their CO2 down. It's amazing. And they'll do it on their own. So, and, that's the best way that this can happen. And the problem is, when we use invasive mechanical ventilation for these patients, it's really hard to blow a CO2 down that low. And so as much as possible, if you can keep these patients, breathing spontaneously on their own, that's really the best thing to do. Obviously this patient, the way he was described came in, completely unresponsive, GCS of 3. He was going to need to be transported. So, at some point it's a safety issue. So you do what you got to do. But if you're in a place where they're going to stay, where you are, and you can watch them and act if something happens, the best thing is to keep them spontaneously breathing. And it's impressive sometimes the neurological status. Just by rehydration at first and getting the sugar down a little bit, they're going to wake up, within 2 or 3 hours. They're not going to talk to you or you'll be able to chat or whatever, but just, enough that you'll feel safe, that they're okay. And, they'll control their own CO2, which is the best.
So let's talk about Winner's formula, right? So I just corrected that. And so based on Winner's formula, the total compensation for this guy is 10.25. Right? With that CO2. So how much does that play into your decision, if any, to say, hey, this bicarb was 1.2. I need to, let's say this patient was able to breathe on his own. I guess it doesn't really matter, right? Whether they're intubated or mechanically ventilated, you're going to set that minute ventilation. But does giving bicarb in that example, because that allows you more respiratory compensation, is that ever a consideration, or do you just not worry about that?
Yeah, in DKA, on itself, I wouldn't, just because of what we talked about before. But certainly, your point is great for another pathology. Certainly that would make sense. The only thing, your point was great. We talked about this before. You just have to, know that, bicarb is going to become, CO2. Right. Once you're going to give, sodium bicarb, it goes with the hydrogen and becomes CO2, in water. And so you want to make sure you're going to be able to breathe that out. And so if your invasive ventilation, minute ventilation is not high enough, once you're going to give bicarb, not only, on the short term, we think it probably makes pH a little bit worse, especially when you do, pushes of bicarb, contrarily to, isotonic bicarbonate infusions. But, if you don't increase your minute ventilation, you're just going to switch the problem. Your pH is going to stay the same. You're just going to, change the numbers of your equation. So I loved, and I don't know if you want to give us your calculations that you were using for minute ventilation, but I really liked how you presented that.
Yeah. So these calculations were initially taught by Scott Weingard, like way back, right? In his initial metabolic acidosis minute ventilation formula, which we used and taught at FlightBridgeED for a long time, was 240 mils per kilo per minute. Now, over the years, working with other medical directors and talking to other intensivists, I think we've been more conservative. If conservative is the right word, we've lowered that down. And so standardly, we teach 160 mils per kilo per minute. And so if you're starting at 6 mils per kilo on your tidal volume, that is a rate of 26. Right. So you don't ever have to do the math. Start at 6 mils per kilo. It's going to be the same no matter how many kilos the patient is, ideal body weight. And that's a whole other subject. And maybe I'll chime in on that. But when you look at minute ventilation for this patient, rate of 26, that's a good starting point, right? And so 6 mils per kilo, they actually on this patient had the minute ventilation much lower. They set a rate of 18, tidal volume around 500. Definitely made me a little uncomfortable, especially with the ABG as it was. And so I think that the big education piece is if you are able to get an ABG and you have that information, if you have point of care testing, whether it's ISTAT, EPOC, man, if you identify partial compensation, you have to set that minute ventilation at a number that is going to protect you and the patient, right? 26 is a starting point. That might not be enough. There's definitely a trade-off with a higher rate, right? We lose more in anatomical dead space, which can impact the patient hemodynamically. And so that there's a trade-off there. This patient also had norepinephrine, as we said, but the blood pressure was 118 over 80, right? So as norepinephrine started prior to the flight crew getting there, and be okay with saying, hey, I've got a great map. This is a young patient. Was the norepi on because the patient was on 150 mics of propofol, right? Can you change that out? So don't be afraid to DC that off. That was another question I had, is why was the norepi continued? I did not see the need for that. And if we can reduce the pharmacology, I think your patient is better off. So you got to be able to evaluate what is going to be my biggest threat. If you don't have an ABG, now this patient had an ABG, but what if you don't have an ABG in flight or in transport? That's okay, right? You have other tools. Assume it's what it is, right? Assume that you are going to continue in partial compensation. That's not going to change overnight. You set that minute ventilation at a number that is going to give you, kind of that safety margin. The other thing I would say is oftentimes we say, well, what is the pre-intubation minute ventilation? And what is the pre-intubation end-tidal CO2? And what I say there is pre-intubation end-tidal CO2 is only as good if hemodynamic status is stable, right? If it's not stable, there's no utility in using it because you don't know why it's low. Is it low because, well, you do know why it's low. It's low because of perfusion. It's low because of partial compensation. So you can't really use that. So I think you got to use just err on the side of caution and say, hey, this is a standard male, 70 kilos, 80 kilos, probably breathing 400 to 500 mils every breath. You could say 500 at a rate of, whatever the rate was, right? And get whatever that rate was. And that's your starting minute ventilation. And so that's what you would target is that number. So there's a lot of thought process there. I don't think it's a perfect science. I think you just have to err on the side of caution. And I'm not a medical director, obviously, but if I was a medical director, I would want my crews to err on the side of caution. I'd rather them set a minute ventilation high than low. You obviously have an ABG also on here that has a base excess of 29. I don't know if you want to kind of talk about how that guides your resuscitation, but I think that is an important piece long term for crews to be able to identify where is the acidemia coming from. Now, for this guy, we know it's probably ketones, the SID between sodium and chloride. I don't really think there's alterations there. There's not a big chloride load, and so it's probably ketones. We didn't get a lactate on him. Is there any lactic acidosis? Might be mild, but how does that guide your long-term resuscitation in this patient, or does it? Or is that more reserved for these other severe metabolic acidemia patients?
Yeah, I think for DKA, a little bit less, but it's interesting, I think, to go through all these calculations and find the especially when you have a differential diagnosis there, which I think we need to have with this patient, who's really sick. Is there infection and lactate is playing a role? Is there like something like a toxic alcohol or aspirin on board or something like that? So for sure, that would definitely play a role. Yeah.
One of the last things I want to talk about is really the selection of sedative agents, right? And there's lots of different ways to manage patients long-term with mechanical ventilation and transport, right? We had great discussion pre-show about, there's a lot of utility with ketamine. Obviously, ketamine is used for your standard induction agent. We definitely lower the ketamine dose for high shock index patients. Ketamine drips are used pretty consistently. Fentanyl drips are now used consistently with bolus doses prior. But what are your thoughts on the use of propofol in this patient?
Yeah, so a few things. So first of all, it was described the patient came in unresponsive. So from what I understand, the intubation, happened with very little medication on board. So the first question is, do you need to have that much sedation on board? 150 mics per kilo per minute is a lot of propofol. I think, always, I know you've taught that in the past, analgesia first, right?
Yep.
So I think probably, a little bit of analgesia for this patient, even if it's just like a bolus of a medium acting agent, IV, obviously. And, fentanyl drip is a perfect option as well, just like a very low rate just to get something in there for transport. And after that, if the patient is still agitated or anxious or something going on, then for sure, I think propofol is a good choice. We were talking offline, probably not the best choice for transport, but certainly a good choice for critical care. A lot of these patients will be on propofol for sure. But I think the most important thing, and I think the point to get out of this case right here is you need to, in the best of your knowledge and capacities, to try to use rules or tools, tools for looking at pain. Does this patient need analgesia? And then tools for looking at agitation, right. Whichever tool you use. Yeah. And I don't think this patient, in the state that they were in, required, for sure that profound dose of anesthesia almost, right? Yeah. Sedation. And so I think probably bringing that down, and that's what the crew did when they arrived, right? Bringing down the propofol dose to a lower rate. I think that was a great idea. And the other thing is, you were talking about the norepinephrine before. I wonder if the norepinephrine wasn't just because of the propofol dose. So, right. If you lower your propofol, then probably you'll get away with, taking your norepi drip off completely. So that would have been very interesting to see.
Yeah, the whole conversation on propofol, I told you pre-show, I've just never been a fan, right? And it doesn't mean that it's right or wrong. That's my opinion and that's my experience. I know a lot of colleagues, a lot of peers that I'm friends with that love propofol in transport, right? So if you're listening and you love propofol, then that's great, right? Use it within your guideline and use it safely, and it definitely has utility. I have not had good luck with it. I would prefer to use other agents. I just think that it's easier to use, it's easier to manage. And part of that is also, if you have it available to start, you're probably much more apt to grab it, right? But any place I've worked, it's always been in the guideline to use and continue from a hospital, but we never carried it. And so, you just learned to use other agents. You became more comfortable with those agents and you trusted those agents much more, right? So I'm not saying there's not utility. I know it's used safely every single day somewhere. Just my opinion is that for me, it's probably not the best, for when I'm taking care of a patient, I'm going to use something else. Right. And so, no harm, no foul. If it's within your guideline and you have great luck with it, continue doing what you're doing.
Yeah, no, that's interesting. And the main reason why we like propofol is it's fast on, fast off, right? So when you want to assess your patient, re-examine your patient, that's going to make things easier. Obviously, there's a downside about hemodynamic instability, which, especially when you're in transport, can be, harder to check on a frequent basis. So that could be a problem as well. And, the other thing is we try to shy away from the higher doses, especially because of all the risks with propofol-related infusion syndrome. Obviously, that won't happen within a few hours. But, certainly trying to stay, below 80, max 100 mics per kilo per minute. You need to think about that if you're using it for a longer term. And, the final point I want to make is, we feel that initially, either in initial resuscitation or the first few hours, even if we sedate the patients a bit more, it's not going to be that much of a problem. But we have a lot of studies that show that the most sedated the patients are when they get to their final destination, be it in ED and ICU or whatnot, that, when you check hours later and days later, they tend to be more sedated if they were more sedated initially. So what happens is, practitioners will say, oh, this patient has that high of a dose of propofol. Was it because he was agitated? Should we keep it on? We don't want to titrate it down too fast. So what's going to happen is we see that in studies that even days later, the patients that are highly sedated initially during resuscitation or transport will have a tendency to be sedated more later. So we actually do a disservice to our patients when initially we give very high doses and, we find them that they're, completely out. So obviously when you're in transport, you want things to be safe. So that for sure is a very important point. But as soon as you can, try to lower your doses and try to lower your drip rates, you want to do that as soon as possible.
Do you guys use a Ramsey score? Is that how you use?
We use RAS, Richmond Assessment Sedation Score. Yeah.
Yeah. And I think that's another side that like a lot of us don't see, right? Obviously the nursing side, if they're working in the hospital, they probably see that. So I would assume that then that leads to delirium, right? And that leads to, long-term issues. We know delirium leads to disability, and there's a major problem.
Yeah, delirium, prolonged sedation, prolonged intubation, and all these things. And, it's really weird because you would say, well, it doesn't matter when they get to the unit, why did they just titrate the meds down? But that's not how it works. People, they need to, it takes a few hours for them to settle in, and then just to make sure everything's fine. And then they're like, oh, why is that drip rate so high? There must be a reason. So we're not going to turn it down too fast. So, all these biases come in and make the staff a bit leery about getting the sedation down too fast. And so these patients will be more sedated for longer periods.
Well, man, this has been great. Look forward to doing more podcasts with you.
Yeah, thank you so much. It's amazing.
Any parting words?
No, thank you so much for the invitation.
Right.
I'm just really happy to be here in person with you.
Thanks, man. Appreciate you.
Thank you.
We'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.